Good evening, I'm Belva Davis, and welcome to This Week in Northern California. Joining me tonight on our news panel are Paul Rogers, San Jose Mercury News environment writer, and Josh Richmond, Bay Area News Group's political writer. We start tonight's program with a look at Thursday's highly anticipated ruling by the U.S. Supreme Court upholding key provisions of the Affordable Care Act. How does the decision impact California, where reform is already underway?
We love Obamacare!
The Constitution does not allow for mandates.
The ruling surprised many who had anticipated the court might strike down the individual mandate requiring most Americans to purchase health coverage. But it came as welcome news to many health care officials here in California, home to an estimated 7 million uninsured.
So you have to brush your teeth, okay?
The state has already passed legislation to guarantee coverage for children with pre-existing medical conditions and for young adults to stay on their parents' policies until the age of 26, both provisions of the federal reform. And the state has already used $40 million in federal funding to develop the Health Benefit Exchange Program, a centerpiece of the 2010 legislation. The exchange will create a new online marketplace of affordable health plans for consumers to choose from, to take effect in 2014. Some may qualify for subsidies.
In order for you to be eligible to Medi-Cal, these are some of the requirements.
While the ruling did strike down the requirement for states to expand Medicaid for low-income individuals, California has embraced the option to expand Medi-Cal, the joint state-federal program for the poor and disabled. The state could receive about $50 billion from the federal government, and about 1.5 million people are expected to be newly covered by the program. But California is about to transfer nearly 900,000 children to Medi-Cal because of the elimination of the Healthy Families program in the state budget, adding strain to that system. And to hear more about the impact of the ruling on California, Diana Dooley, California Secretary of Health and Human Services, joins us now from Sacramento. Welcome, Secretary Dooley.
Thank you, Belva.
Your agency is responsible for implementing the health care reform. So what comes next?
Well, we have been on the path to healthcare reform for a very long time in California. We've had many starts and stops. In 2010, we began to implement the Affordable Care Act by the establishment of the Health Benefit Exchange. We've been meeting for the last year and a half since the exchange started in January of 2011. We have many pieces in place, but we have much more to do. We have been operating at full speed to this point, and now we have to find a gear even higher than that and move into warp speed to get all the work done that we must in order to have the coverage that people need in January of 2014.
So you've been operating on faith that this would work out. And so far, it looks like that things are going well for California. But could you explain the key point of debate? And that was over the mandate. What exactly is it, if it can be explained quickly? And is it all that this is all you could have possibly expected, I guess, from the courts?
Sure, it is what we hoped for, and the idea of an individual mandate coupled with the subsidies that the federal government will provide to make the insurance affordable for people is like a carrot and a stick, and it's mirrored very directly after the Romney plan in Massachusetts that has also a mandate and also a subsidy. We need to incentivize people to get the care. Most people want to have the security that comes from having health insurance, but for many middle-income families, they can't afford it. For families of 4 up to $90,000 in annual income, which is 400% of the federal poverty level, they will be eligible for subsidies through the exchange to purchase their insurance. If they choose not to purchase insurance, they will pay a penalty that the court called a tax for their choice not to buy insurance. And that will go to help help underwrite the costs of their care when they need it. Many people think that they won't need care, but then they find themselves in an emergency room, and the cost of that care is then borne by everyone else who is covered by an insurance plan that they pay for themselves or that their employers provide for them.
That no free riders idea is a pretty conservative idea going back. Is there any idea, though, any estimate of how many people in California might in fact not seek coverage and thus be subject to that penalty tax? Or
it actually is quite a conservative idea, and it's one that Republicans have embraced in the past, the individual mandate. They were advocates of the individual mandate in California in 2007 when Governor Schwarzenegger proposed it. We don't have any estimates in California. We're going to do all that we can to communicate with the public in ways that will persuade them that the security that comes from having insurance is better than being one accident or illness away from bankruptcy. In Massachusetts, which is our best example, less than 2% of the people have remained uninsured. That would be a very fine goal for us in California.
Madam Secretary, I think there's a lot of folks out there who have paid very little attention to this, frankly, in the last year and a half, and they're kind of overwhelmed by the complexities, and they're just catching up. So a couple of the real quick questions that I see coming up again and again on the internet and on talk radio, things like that. First, how much is the penalty if you don't have insurance? Second, are illegal immigrants covered by this program? And finally, is it likely that many private employers are going to drop health care because the government's providing it now?
Well, the first question is the penalty ranges from about $600 to $1,000, depending on the circumstances. So the reason that we in California thought that we might be able to implement this anyway, even if the mandate was stricken, is that it's a relatively weak mandate. The cost of paying the penalty is less than it would be to buy the insurance. The combination of the subsidies and the pricing that we hope to be able to get for the insurance will make it attractive to them. The question of the illegal immigrants, they are expressly excluded. They are excluded from the Medicaid expansion, and they are excluded from the opportunity to buy on the exchange. Those who are undocumented must remain in the private unsubsidized market if they have insurance at all. And the third question, you'll have to remind me again.
Are private employers likely to drop their coverage now?
Well, there has been a significant drop in small employer coverage just because of the effect of the Great Recession. The choices that will be available, we're working very closely with the small business majority in the Bay Area Council and many small representatives of small employers to work cooperatively with them. One of the advantages that the exchange will offer for their employees is the choice between plans. Most small employers, because of the cost of insurance, have to have all of their employees in one plan. If they choose to have their insurance through the exchange, those employees will be able to have a choice of plans by purchasing on the exchange. The employers will pay a price, but that cost to the employers may be less than it would be to continue the coverage. And so I think we'll work cooperatively with the business community to make it a win-win for them and for their employees as we move forward.
What about the often said charge that cost will go up, that because of this, cost will increase?
Well, we really think that this can help us control the skyrocketing cost. Premiums increase because healthcare costs increase, and there are many provisions of the Affordable Care Act that will allow us to change the incentive structure so that people are paying for value instead of volume. In a fee-for-service system, as we have primarily, you get paid for procedures and visits and diagnostic examinations. If we can move to a value-based pricing system, which is incentivized by the Affordable Care Act, we will be able to control cost, and that will be able to control the premiums. I think that we won't go backwards. I think holding down the rate of inflation will be a significant benefit, and that is our goal, and that's what we hope to do.
Who will qualify for subsidies? What will be the criteria?
The criteria is income-based, and it is a percentage of the federal poverty calculation for up from 200% up to 400%, actually from 138% up to 400% of poverty, up to 138%, which is about $30,000 for a family of four. They will be eligible for the state program Medi-Cal. Above that, between 138% or between, to put it in numbers, about $30,000 a year to $92,000 a year, there will be a sliding scale of subsidies that will help pay for the insurance that people will be able to buy. And there will be a range of products that will be offered through the Health Benefit Exchange. The Benefit Exchange will be a place where our goal is to make buying insurance as easy as ordering a book on Amazon.
What's the current status of that? I mean, how this has to go live next year. Some states haven't even started it yet. I know California has been a leader in getting this going, but how much of that platform is built?
We're well on our way. We have sort of three main things we have to do. We have to have a system for people to enroll in the programs, and we have recently awarded a contract. We had a very robust bidding process. We have awarded a contract to an information technology company that will build an IT system for us, a website and web capability that will be used by county programs to enroll people both in Medi-Cal and in the insurance product. We are building call centers that will be available to route information and make what we hope to be a first-class consumer experience. And we are working with the health plans to design the products and to establish the criteria that health plans will have to meet in order to sell their product on the exchange. Our goal is to have this simple, straightforward, that people who need to buy insurance will be able to know what they're getting, what it will cost, and which doctors and hospitals will be in the network if they, for each plan that they will have the option to buy.
Secretary Dooley, we really appreciate your joining us for this explainer on something that California seems to be ahead of the curve on. Thank you so much.
You're very welcome.